image analysis of the cervical spine. For the AP axial cervical spine, you're going to want to see the spinous processes are aligned to the midline of the vertebral bodies. The mandibular angles and the mastoid tips are equal distance from the cervical vertebrae. The articular pillars and pedicles are symmetrically demonstrated lateral to the cervical bodies. Here are the articular pillars, and the pedicles are seen here. The distance from the vertebral column to the medial end of the clavicles also demonstrate no rotation. Intervertebral disc spaces are open. The vertebral bodies are demonstrated without distortion. Each vertebrae spinous process is visible at the level of its inferior intervertebral disc space, seen right here. The apiaxial effect on the cervical rotation. So the upper and lower cervical vertebrae can demonstrate rotation independently. So if the head is rotated but the thorax is not, the upper vertebrae will demonstrate rotation. Now if the thorax is rotated but the head is not, the lower vertebrae will demonstrate the rotation. Rotation is present if the mandibular angle and the mastoid tips are not at equal distance from the cervical vertebrae. The spinous processes are not demonstrated in the midline of the cervical bodies. The medial end of the clavicles are not demonstrated at equal distance from the vertebral column. The vertebral bodies move towards the side position closest towards the image receptor. The spinous processes move towards the side position furthest from the image receptor. Here we have the rotation. We have a patient who is rotated towards their left side. Then we also have a patient who's tilted and the head is not, the face or the mandible is not positioned where it should. The mandible should be superimposed with the occipital bone. For the open mouth, the axis or the atlas is symmetrically seated on the axis, so on the dens here. The lateral masses are equal distance from the dens. The spinous process of the axis is aligned with the midline of the axis body, right down here. The mandibular rami demonstrated at equal distance from the lateral masses. Here are the here's one, the right side, and the left side, the rami. The atlantoaxial joint is open right through here. The axis's spinous process demonstrated in the midline, slightly inferior to the dens. Right here is the spinous process. So the effect of rotation on the open mouth. If the patient is rotated, the lateral mass is located on the side from which the face is turned. The lateral mass and dens narrows. To determine the way the face has turned, judge the distance between the mandibular rami and the lateral mass. The side that demonstrates the greatest distance is the side the face is rotated towards. So we have the greatest distance here, so the patient's face or head is rotated towards the right. Effect on flexion and extension. If the patient is flexed, the atlantoaxial joint is closed. The spinous process of the axis is demonstrated closer to the dens. If extended, the atlantoaxial joint is closed and the spinous process of the axis is demonstrated more inferior to the dens. This one, the head is extended. The lateral position. The cervical vertebrae demonstrate in a lateral position. The anterior and posterior aspects of the right and left articular pillars and the right and left zygapophyseal joints of each cervical vertebrae are superimposed. The spinous processes are demonstrated in profile. The posterior arch of C1 and spinous process of C2 are in profile without posterior occiput superimposition, so no superimposition of the occipital bone. The body's demonstrated without mandibular superimposition, so the mandible is away from the spine. The cranial cortexes and the mandibular rami are superimposed, so we have one outline of the bone. The superior aspect of the right and the left articular pillars and zygapophyseal joints on each vertebrae is superimposed. Again, I can't say it enough, the zygapophyseal joints are demonstrated on the lateral cervical spine. The intervertebral disc spaces are open, and the fourth cervical vertebrae is centered within the collimated field. To detect rotation on a lateral cervical spine projection, evaluate each vertebrae for anterior and posterior pillar superimposition and zygapophyseal joint superimposition. Difficult to determine which, from a rotated lateral image, which side the patient is rotated. There is magnification on the side situated furthest from the image receptor. As you can see here, we have kind of a lightening effect to the zygapophyseal joints. That means the patient is rotated. So for accurately positioned PA or AP axial oblique, the cervical vertebrae have been rotated 45 degrees. The 2nd through the 7th intervertebral foramina are open. The pedicles are of interest are in profile. So here are the pedicles. This little piece that projects posteriorly are the pedicles. The intervertebral foramina are open. The sternum and the SC joints are demonstrated without superimposition with the spinal vertebral column. The intervertebral disc spaces are open. The cervical bodies are demonstrated as individual structures. The posterior arch of the atlas is demonstrated without self-superimposition, demonstrating its vertebral foramina. The inferior outline of the outer cranial cortex or cortex and mandibular rami are demonstrated without superimposition. The effect of improper rotation, so not enough rotation, the intervertebral foramina are narrowed or obscured, the pedicles are foreshortened, and the portion of the sternum or one of the SC joints will be superimposed with the vertebral column. Too much rotation. One side of the pedicles is partially foreshortened, but the other side is aligned to the midline of the body. Here we see the circle area of that's superimposed in the body. That is actually the pedicle of the other side. The zygapophyseal joint demonstrated without vertebral body superimposition. You could possibly see the zygapophyseal joint starting to open for an excessive amount of rotation. We're going to move into the positioning or the anatomy and positioning for the soft tissue neck, upper airway, or upper respiratory system, however it's ordered at the clinical sites. So the anterior portion of the neck is where we're going to start with our anatomy. The principles, it is the upper respiratory system as well as the upper digestive system. It is one. We do have the thyroid gland, the parathyroid gland, and a large part of the submandibular salivary glands. So starting out with the pharynx, it serves as a passage for food and air. It is the common area for the digestive and respiratory system. It is a musculomembranous tubular structure located in the front of the vertebrae and behind the nose, mouth, and larynx. It extends from the inferior body of the sphenoid and basilar portion of the occipital bone to C6, C7. At the level of C6, C7, it becomes a continuous portion into the esophagus. It is subdivided into three portions: the nasal pharynx, oral pharynx, and the laryngeal pharynx. So here's a cross-section image of the pharynx itself and the three different levels of the nasal, oral, and laryngeal. The nasal pharynx lies posteriorly above the soft and hard palates. It communicates anteriorly with the posterior aperture of the nose, whereas the oral pharynx is the area of the pharynx extending from the soft palate to the hyoid bone. It is the base of the tongue. It forms the anterior wall. Then, last is the laryngeal pharynx. It lies posterior to the larynx or the voice box. The anterior wall formed by the posterior surface of the larynx. It extends inferiorly to become continuous with the esophagus. The organ, the larynx, is used for voice. Its division is part of the respiratory system. It serves as an air passageway between the pharynx and the trachea. It is movable, is a tubular structure. It is suspended from the hyoid bone. It extends from the superior margin of C4 to the inferior margin of C6. The epiglottis is situated above the laryngeal entrance. The epiglottis is used to prevent food from moving into the trachea during the swallowing motion. So the respiratory and stress maneuvers that will be done during imaging. Quiet inspiration. These tests are done to see the abduction of the vocal cords. Normal phonation or making noise. I will test the adduction of the vocal cords. And inspiration will demonstrate the laryngeal ventricles. The Valsalva maneuver tests the elasticity and the functionality of the glottis. The modified Valsalva maneuver will test the elasticity of the laryngeal pharynx and the piriform recesses. The imaging of the pharynx and larynx includes an AP and a lateral. The AP is done with the patient upright. Mid-sagittal plane is centered to the grid. The shoulders are at the same horizontal plane. Your IR is centered to or just below the level of the laryngeal prominence. Ensure that the mandible is not within the anatomy. Your central ray is perpendicular to the laryngeal prominence or Adam's apple. And the exposure is made during one of the inspiration or respiratory maneuvers or stress maneuvers. For the lateral projection, the patient is upright. Mid-sagittal plane is parallel to the image receptor. You're centering to the center of your image receptor. Shoulders are depressed, head is slightly extended. Your central ray will depend on where your anatomy of interest is. Is it the nasal pharynx? You're going to be centered 1 inch below the EAM, that's the external auditory meatus. For the oral pharynx, your central ray will be entering at the level of the mandibular angles. For the laryngeal pharynx, or the upper esophagus, will be centered at the laryngeal prominence, or the Adam's apple. It all depends on where the anatomy of interest is located. Here is a radiograph of the lateral projection. The exposure was made using one of the respiratory or stress maneuvers, where we can see the air-filled pharynx, laryngeal pharynx, the hyoid bone, within the soft tissue of the neck. We do have pathology here. We have a calcified hematoma in the thyroid gland and also a large cyst on the epiglottic fold in the piriform recess. That is the end.